बढ़िया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's session, we are going to continue with the different types of anemias. In the previous lecture, we have discussed about anemia. We have discussed about the iron deficiency anemia. What are the different clinical features and how to investigate anemia and how to manage it. So we have learned about the classification of anemia, and we have also discussed about the most common type of anemia that we are going to see in our clinical practice, that is the iron deficiency anemia. In today's session, we are going to discuss about the megaloblastic anemia. What is megaloblastic anemia? What are the clinical features? How can we diagnose the case of megaloblastic anemia? How can we investigate and how to manage a case of megaloblastic anemia? So today we are going to discuss everything about megaloblastic anemia. So let's start with this topic. What is megaloblastic anemia? Deficiency of vitamin B12 or the folic acid from the disturbance of folic acid metabolism. This is associated with megaloblastic anemia. So in the megaloblastic anemia, there is deficiency of either vitamin B12 or folic acid, or from the disturbance. So there are two things that we have to remember in case of megaloblastic anemia: deficiency of vitamin B12 and deficiency of folic acid. These are resulting from the disturbance of folic acid metabolism. And vitamin B12 deficiency is associated with neurological diseases in 40% of the cases. So if there is vitamin B12 deficiency, but not the folate acid deficiency, then it is associated with different type of neurological diseases that we are going to see in the today's lecture. The cause for the megaloblastic anemia, there are two causes, as I have told you. One is vitamin B12 deficiency, and the second one is the folic acid deficiency. Now, first of all, we will come to know about the causes. What are the different causes for vitamin B12 deficiency and what are the different causes for folic acid deficiencies? Vitamin B12 deficiency, this deficiency we are going to see, this is very common these days and it is occurring in a lot of people. So vitamin B12 deficiency, it is occurring due to the inadequate intake of the diet that is seen in case of strict vegan diet or the poor quality of diet. So because of the inadequate intake that is seen in case of vegan diet and poor quality diet. Second is the malabsorption. When the patient is taking proper diet, but the food is not getting absorbed from the intestine. Malabsorption, that is seen in case of gastric and small intestinal diseases. There are also different type of gastric conditions that we will see in case of pernicious anemia, congenital intrinsic factor deficiency, gastrectomy. These conditions are also responsible for the vitamin B12 deficiency. What are these? Pernicious anemia, congenital intrinsic factor deficiency, because we know intrinsic factor is responsible for the absorption of vitamin B12 from the intestine, and gastrectomy, when a part of intestine is removed. We also have small intestinal factors, which includes the bacterial growth, overgrowth. We have Crohn's disease, tropical sprue, and severe pancreatic diseases, and different type of drugs that are acting upon the small intestine and leading to the non or the malabsorption of vitamin B12. So vitamin B12 deficiencies because of inadequate intake, there can be malabsorption, various gastric factors, and the small intestinal factors that are responsible for the malabsorption of vitamin B12. Now, folic acid deficiency. The folic acid deficiency occurs because of the inadequate intake. This is the most common thing. If the patient is not taking the food properly, then it will result into the development of folic acid. Inadequate intake at infancy, old age, due to poverty, or due to excessive alcoholism. There is also malabsorption syndrome that is seen in case of celiac disease, tropical sprue, dermatitis herpetiformis. In this condition also, folic acid cannot be absorbed. Increased utilization or loss. Folic acid deficiency is also seen in the condition when there is increased utilization that can be seen physiologically in case of pregnancy or lactation, or it can be pathological conditions when there is excessive blood loss disorders, there is malignancies, we have dialysis or severe inflammatory diseases. Next, we have antifolate drugs. If a patient is taking knowingly or unknowingly antifolate drugs like methotrexate or anticonvulsant drugs, then it can also lead to the development of the folic acid deficiency. So folic acid deficiency, we have again inadequate intake, we have malabsorption, increased utilization of or loss or the antifolate drugs. Now, what are the clinical features of megaloblastic anemia? Whenever a patient of megaloblastic anemia is coming to us, how can the patient present to us? So in the case of megaloblastic anemia, we are going to have the symptoms and the signs. So first of all, let's start with the clinical features, the symptoms. In case of megaloblastic anemia, the patient will have malaise. Malaise will be seen in 90% of the cases, and there will be breathlessness in 50% of the cases. So there will be malaise and breathlessness. There will also be paresthesias, different type of paresthesias. We also have sore mouth. So malaise, that is seen in 90% of the cases. Next, we have breathlessness in 50% cases. Paresthesias, we have sore mouth. There is also weight loss with altered skin pigmentation. There is gray hair, impotence, poor memory, depression, personality changes, hallucination, and visual disturbances. So the clinical features includes in the symptoms, the patient will complain of malaise. There will be breathlessness, paresthesias, that is abnormal sensations. There will be soreness of the mouth. The patient will complain of weight loss. There is also altered skin pigmentation with gray hair, impotence will be there, and poor memory. There will also be depression and personality change with hallucinations and visual disturbances. So the patient has all these kind of symptoms that he or she is coming with megaloblastic anemia. Next, we come to the signs that we are going to observe in the patient. The signs will include a clear, smooth tongue. There will be angular cheilosis with vitiligo and skin pigmentation. So you can see vitiligo, there will be skin pigmentation. There can be heart failure and pyrexia. So in the megaloblastic or B12 deficiency, there will be smooth tongue, there will be angular cheilosis, there can be vitiligo, skin pigmentation, heart failure, and pyrexia. Now, there are various neurological symptoms that will be seen in case of vitamin B12 deficiency, that is known as B12 neuropathy. Due to the symmetrical damage to the peripheral nerves, because of the symmetrical damage that we are going to see in the peripheral nerves, legs and are affected more than the arms. So in the neurological diseases or the neurological symptoms, we are going to observe because of the symmetrical damage to the peripheral nerves, these are more common in the arms. So you are going to see neurological defects in the arms. There will also be neural tube defect because of the vitamin B12 deficiency. You are going to observe different type of neural tube defects among the children. That is going to cause spina bifida, encephalocele, and encephalopathy. So folic acid deficiency during the pregnancy will cause spina bifida. Therefore, folic acid tablets are given during pregnancy. So due to the deficiency of folic acid, because it is the demand is increased during pregnancy, and if the demand is not fulfilled for the folic acid, then it will be responsible for development of the neural tube defect, causing spina bifida, encephalocele, etc. There can be gonadal dysfunction because of the deficiency of vitamin B12 or the folic acid. It will cause sterility, and that sterility is reversible. There will be epithelial changes that includes glossitis. In the CVS cardiovascular system, there will be raised serum homocysteine concentration, and it is associated with arterial obstruction and venous thrombosis. So there will be raised serum homocysteine level, the concentration is associated with arterial obstruction and the venous thrombosis. Now, what are the various investigations that could be done for the megaloblastic anemia? The investigations includes hemoglobin level checking. The hemoglobin will be reduced in such cases. Mean corpuscular volume, because its name suggests megaloblastic anemia, that is the size of each RBC is increased. Therefore, the MCV will be raised and it will be more than 120 femtoliter. Lactate dehydrogenase will be raised in such patients, and we are going to see serum ferritin level, the serum ferritin, that is iron demand, that is increased. The blood film will show macrocytosis, and in the bone marrow examination, there will be differentiated B12 folate deficiencies from non-megaloblastic causes such as alcohol and liver diseases. So bone marrow examination will help you to differentiate whether it is B12 deficiency, folate, or megaloblastic cause, or it is due to alcohol or liver disease. Serum B12 and folate assays can be done And in case of vitamin B12 deficiency, it is less than 110 nanogram per liter. How to manage a case of megaloblastic anemia? Whenever a patient of megaloblastic anemia is coming to us, we have to do the management or supplement both folic acid and the vitamin B12. Vitamin B12 deficiency is treated by the injection of hydroxycobalamin, that is 1000 microgram intramuscular in 5 doses, 2 or 3 days apart. And it is followed by the maintenance therapy of 1000 microgram every 3 months for life. Oral folic acid 5 milligram per day for 3 weeks is usually given to treat the acute deficiency, and 5 mg once a week is given for the maintenance therapy for the deficiency of folic acid deficiency. So this is all about the megaloblastic anemia. Now we will also start pernicious anemia because it is also related to this particular thing. What is pernicious anemia? Pernicious anemia, it is basically an autoimmune disorder and in which the gastric mucosa is atrophied. So what is happening in the pernicious anemia? The gastric mucosa is getting atrophied, because of which the absorption of vitamin B12 cannot take place. So there is atrophy. The mucosa goes into atrophy, and there is loss of parietal cells. And this loss of parietal cells will cause intrinsic factor deficiency. And in absence of intrinsic factor, less than 1% of the dietary B12 is getting absorbed. So in the pernicious anemia, there is deficiency of the intrinsic factor. This deficiency of the intrinsic factor is arising because of the atrophy of the gastric mucosa. All right. Now, age of onset of pernicious anemia is around 40 to 60 years of age, and it is more common in the females. There is a strong family history association, and it is more common in the individuals with other autoimmune disease like Hashimoto thyroiditis, Graves' disease, vitiligo, hypoparathyroidism, or Addison's disease. So the age of onset is 40 to 60 years. With the sex, it is more common in females. Strong family history association is there, and it is more common in the individual with autoimmune disease like Hashimoto thyroiditis, Graves' disease, vitiligo, hyperparathyroidism, and Addison's disease. And now, what is the diagnosis of pernicious anemia? How we are going to diagnose pernicious anemia? We have to check for the intrinsic factor, because as I have told you that this is due to the pernicious anemia is due to the deficiency of the intrinsic factor that is arising because of the erosion of the gastric mucosa. And because of the deficiency of intrinsic factor, the vitamin B12 is not getting absorbed from the intestine. So the diagnosis is done by finding the anti-intrinsic factor antibodies in context of vitamin B12 deficiency. That is the diagnostic for pernicious anemia. We can also check for the antiparietal cells antibodies that are present over the 90% of the cases. But these are also present in 20% of the normal females over the age of 60 years. We can also check for the patients with lower B12 levels and negative anti-intrinsic factor antibodies, and should have done the Schilling test performed. What is Schilling test? This I have given you in the e-notes that I've uploaded. So you must go through the e-notes or the book, and you have to check for the Schilling test. Schilling test is important for writing about the pernicious anemia. If you are not writing about Schilling test, that means you don't know much about the pernicious anemia. So for detecting the low levels of B12 and negative anti-intrinsic factor antibodies, we have to perform the Schilling test. So it's your homework to write about the Schilling test. I've given you the details of the Schilling test in the e-notes that I've uploaded. So it is conducted in 2 parts. This you have to check from the e-notes, and then you have to write about it. Now the treatment of the pernicious anemia, because we know that there is deficiency of vitamin B12 in case of pernicious anemia. So vitamin B12 has to be supplemented. So vitamin B12 deficiency, we have to give, as we have seen in the megaloblastic anemia, we have to give hydroxycobalamin 1000 microgram intramuscular in 5 doses, 2 or 3 days apart, and it is followed by the therapy of 1000 microgram per every day for the next 3 months of the life. If there is a sensory neuropathy, it may take 6 to 12 months to get corrected. For the folic acid deficiency, we have to give oral folic acid tablets 5 milligram for 3 weeks, daily for 3 weeks, and it is followed by the 5 mg once a week daily as the maintenance therapy. So this is all about the megaloblastic anemia and the pernicious anemia. So I hope you have understood this session properly. And now it's your homework to go through the books, and you have to complete both the topics. And also you have to write the answers that I have uploaded on the portal. So this session is powered by JAYOTI Vidyapeeth Women's University Digital Version 2.0. I hope you have understood this session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. In the next lecture, we are going to start with a new topic. So this was all for today. Thank you very much. Have a good day.